Hi, and welcome to the Future of Dermatology Podcast. I'm your host, Dr. Faranak Kamangar, board-certified dermatologist. We are here to talk about anything and everything dermatology related. You'll hear from me and my guests who are dermatologists, physicians, experts, scientists, residents, and medical students in the field of dermatology. We publish weekly, so if you like what you hear, hit that subscribe button and show us some love, and thank you for joining us.
Hi, we're so happy to have Dr. Errol Craig join us today. I'm so excited for this. Dr. Errol Craig is one of our esteemed dermatologists at Kaiser Permanente. I was lucky enough when I was a resident a long time ago to also have him as faculty at UC Davis, teaching us a lot of amazing things. So today he's teaching us about scabies, which is something that we should talk about more, because when we see patients in clinic, it's always really disturbing to our patients, but it's almost like one of those things, say, oh yeah, you just have this and here you go and here's the treatment and wash through things, but there's so much more of a history to it. So I loved hearing about a book that he just wrote. And so thank you for joining us, Dr. Craig.
Thanks for having me, Farah.
So yeah, I'd love to hear about how did you even I'm guessing you've been researching, you're reading about this topic for a very long time because your book is so well detailed, and just let us know, how did all of this start?
Yeah, sure. Let me introduce my book to those who aren't aware of it. Ooh, let's make sure we get it on. Yeah, there we go. So this is The Itch, and it's a book which tells the fascinating history of scabies over the ages, written from a clinician's perspective. And I've written it to be accessible to the interested lay public, but I do a deep dive, which I think will really be of interest to dermatologists and dermatology residents. The way I got interested, it stemmed after a case that I saw as a resident of scabies, and after the patient was diagnosed and treated and left. It struck me as being odd that everyone involved in the case, the medical assistants, the co-residents, the attendings, were all acting a little weird about it, like, oh, I feel so itchy and I hope I don't take this home and infect my family. And so at that point, I was wondering, like, what do we really know about the transmissibility of scabies? And of course, when you're in the derm clinic, you got the big wall of books there. And so I pulled out a few of the reference books. I didn't really find anything that satisfying to tell me how transmissible scabies was. And it wasn't until I learned about contagion experiments done with live volunteers in World War II that I really realized, like, here's the information that I'm looking for. And I think it's interesting that Kenneth Mellanby's studies probably are still not very well known to most doctors and dermatologists.
That is interesting. And I can just, oh my gosh, these poor people who were so they were infected on purpose just to see what happens?
Exactly. Like, these are experiments that really can't be done today due to ethical standards and considerations, but that was a different time. And essentially what Kenneth Mellanby did was he gathered volunteers, and the volunteers were conscientious objectors to World War II. They didn't want to serve in a military capacity, but they were willing to, volunteer to advance knowledge for all of humanity, and of course, at the same time, it would pay benefits to their country. And so they volunteered to come to his institute and be infested with scabies. And it turned out that, at the time, it wasn't really clear. People had mixed ideas. Some people thought scabies was a disease of filth. Some people thought that scabies was a disease of close quarters and cramping. Other people thought of scabies strictly as an STD. And so Dr. Mellanby started out with the assumption that scabies was spread by blankets or bedding or fomites. And he actually took scabies sufferers and he had them just hop out of bed, and the volunteers hopped right into the bed. And it turned out that he couldn't infest anybody that way with scabies.
That's actually really interesting. This is something that we do freak out about in clinic. I have to tell a recent story. So every once in a while, we'll see someone with scabies, and usually it's somebody you kind of suspect and you test. But every once in a while, there's someone you don't suspect. And recently for me, it was a little cute baby. I was actually kind of thinking it's just atopic derm. And so, you're touching the baby and they're super cute and all of that. And then, at some point you go, maybe I should scrape this, right? Did look under the microscope and heavily infested. I was like, oh my goodness, right? So in those cases, your brain is immediately like, do I now have it? I mean, of course, you treat your patient. Those are the thoughts you have first. And after that, it's, do I have it? And am I going to take this home to your family members? This is actually a really important unanswered question. I have to tell you, I actually had this moment. I was like, do I just freak out about this or not? And I chose to freak out about it. So what I did was I came home, I had very brand new scrubs, and I'd even like paid the extra to get my name embroidered on it, threw away those scrubs. I had pretty cool new shoes that I liked, threw them away. I had this like really nice North Face jacket. I'm like, that's kind of expensive. Also threw that away. Just decided to go totally crazy about it. Probably none of that was necessary. So long story short, this is such a pertinent question to answer. But yeah, no, how do you get it? So in that case where I was, and there were maybe 5 minutes, had gloves on, playing with a cute little baby. What are the odds you took it home with you, or like it lives on your clothes or something?
Very low, very low. And one of the most interesting things that Dr. Mellenby found was that in the beginning, when his volunteers all had less than 50 burrows, there were no accidental infections going on in his institute. Only later, when patients started to develop cases with hundreds of burrows where there are accidental infections, like the house staff or the nursing staff would accidentally catch scabies. So really, scabies, the contagion in scabies is proportional to the parasite burden. And in the same way that we talk about, like viral load with certain viral illnesses, I think with scabies, we should be talking about burrow count, because when the burrow count is less than 50, I think you can very safely be reassured that you're not going to catch anything through casual contact.
That's good to know. It's helpful to know. I should have kept that jacket. It was a nice one. So yeah, I'd love to kind of hear more about that. So the history is fascinating, and that's a history we're not necessarily taught about. But what else did you find that you feel is kind of lacking in our medical education that we haven't touched upon?
Yeah, well, it's interesting that for millennia, physicians have had a very warped idea of what causes disease. Disease is caused by an imbalance of humors and stuff that today we sort of scoff at. And so for the longest time, physicians were treating scabies and all kinds of other conditions through bloodletting, leeches, toxic type medications, right? Whereas village elders, not kind of subscribing to any of that dogma, learned by empiric observation to pluck out scabies one by one with a needle, and you could actually cure people. So you were much better off through the course of most of human history going to not see a doctor to get cured. And I think it's interesting, we assume today that, medicine is at the forefront and we know everything, but, it's a bit of a mixed bag.
That is actually interesting. And it's also the burden of scabies is huge. I also went another time, of course, I see most actually adults with it, even though I'm kind of giving 2 anecdotes of children, but I once had a younger baby too that was not clearing with the topical, and we wanted to go to the oral medicine, but the oral medication has a thing of, I forget exactly what age it is, but maybe it's less than 12 months or 15 months. It's like there's not a whole lot of guidance. So I asked her pediatric derms, took us down this rabbit hole of reading about in other parts of the country or other parts of the world where little babies are infested. This is actually a main problem. Yeah. And it's a huge burden that we don't see as much here maybe, but in certain parts, I mean, it's like a real issue, which is, I presume, why these village elders back in the day, they really had to figure out solutions.
Yeah, and scabies is actually still a huge problem, especially in tropical areas, especially in the developing world. In 2017, the World Health Organization included scabies in its list of neglected tropical diseases. And in those countries, it can be a big deal because there's issues with secondary infection, post-streptococcal glomerulonephritis, and other real serious conditions with serious morbidity and mortality.
And then, so how are most people getting it here? Sounds like you don't get it from just sitting in someone's seat or getting in the bed like they did with the World War II experiments. Is it direct contact and for a certain amount of time?
I think it's close contact. You really need about 10 to 15 minutes of very close contact to catch scabies. So, for example, anyone you share a bed with, that's a good way of catching scabies. Anyone that you have intimate, close skin-to-skin contact for a prolonged period of time. And then the other issue would be in certain institutions and nursing homes. There's sort of a subset of people who wind up developing really high mite burden scabies, which, it could be crusted scabies or it could just be scabies with hundreds and hundreds of burrows. And I think, that can be explosive. And we do see, family members of those patients coming down with scabies, other healthcare members coming down with scabies, and those can be really tough to kind of treat or find everyone who's affected and treat.
It's true. You bring up a really good point too, but that's definitely a population. When you see kind of an elder patient coming in from a nursing home and they're super itchy acutely, that's like top on our differential. But then it kind of makes you wonder, why is that not the case in other really closely, people who are just in close environments? Like let's say little kiddos, they get head lice all the time and pass it to each other all the time. But you're not seeing like crazy outbreaks of scabies, I don't think, in like elementary schools and things like that. So it is kind of an interesting one, like how it has these patterns that we don't quite, I don't know if we have, or maybe we do have the answers, but it's not something that we think about too much.
I think it's a lot simple scabies where the burrow count is less than 50. It's a lot less contagious than people make it out to be. And so I think that's a really important thing as clinicians is when we see cases of scabies, we have to, in our mind, determine whether this is like a low parasite burden or a high parasite burden case. So let me tell you my approach for seeing scabies. I'm very fond of the saying that scabies is both the easiest and most difficult diagnosis in dermatology simultaneously. And of course, if you see someone with burrows on their web spaces or on their wrists and they're itchy at nighttime and they're around itchy people, it's not hard to make the diagnosis. But as dermatologists, a lot of those cases are taken care of before they get to us. Right? We see a lot of the more atypical cases. And so the way I approach this is I sort of try to assume that every itchy patient I see potentially could have scabies, which means that many times a day, it's briefly entering my mind. Could this patient have scabies? And quickly, within a few seconds of looking to someone or talking to someone, you can dismiss that and move on. But if you're not thinking about scabies, you're not going to make the diagnosis.
That's a good way to actually just always have it on the differential. And it's true that sometimes the pattern looks very different and you can kind of easily kind of dismiss it. Do you find you are often scraping, patients coming in? You might be doing it a lot at a much higher rate than maybe the average dermatologist.
I do scrape a lot. I actually find I get a lot of negative scrapings. I think I'm over scraping, but that's okay. The dermatoscope is phenomenal for diagnosing scabies, and so everyone really ought to be using their dermatoscope and feel comfortable with it. Find the burrow. The first time I saw an attending scrape or look for scabies for the burrows, I couldn't believe how close she put her face up to the patient's skin. I thought, what is wrong with her? Does she have a problem with her vision? But no, you really have to get very close to see the burrows. They can be tricky, especially in darker colored skin. And you can see, if you look carefully and find the burrow, at the tip of the burrow, there is a triangular speck, which corresponds to the pigment in the capitulum and the forelegs of the mite. And then if you scrape that and see it under the microscope, all you have to do is that dermoscopy, microscopy a few times and feel comfortable with the microscopic correlation. And at that point, the dermoscopic findings in scabies are absolutely pathognomonic.
That's true. Actually, yeah, once you kind of see it a few times, you start to get a little bit used to it, which is actually the baby that I talked about earlier, but I was totally like, oh, atopic derm. And I'm talking about bleach bats and things. And I'm kind of getting down to looking at the leg. And I saw one of those. I was like, oh, just kidding. Forget everything I just said. I need to scrape. It's true. Once you see it, it's pretty specific for it. And then, so what is your thought process on treatment? Where do you go to, let's say you just diagnose someone. Are you in your head trying to do a lesion count, like a burden count? Like, is this a low burden? Because I don't think that's something we do. Most of us do. I think it's just kind of like scabies and then let's treat. I don't know if we necessarily quantify it into how moderate, mild, moderate, severe type.
Right. I actually mentioned that to one of my resident buddies. I said, hey, when you find scabies, do count the burrows. He said, good, I'm not going to do it. It's a lot of work, right? So I think it might make sense to just in your mind say this is a low mite burden or this is a high mite burden case of scabies and then kind of go accordingly. As a dermatologist, I love topical therapy. I would prefer to use permethrin if possible. However, there are increasing reports of permethrin resistance, and I think it may have a lot to do with your local epidemiology, but there's reports now, I think, out of Austria showing that 3 rounds of benzyl benzoate is more effective in curing scabies than 3 rounds of permethrin. So I think increasingly we're going to be seeing permethrin resistance. I love ivermectin as well. It's great. It's extremely safe. But, if we start using a ton of ivermectin, we're going to see ivermectin resistance as well.
That's actually a good point, because I don't think we think about it with we think about antibiotic stewardship, not using our higher level medicines so we don't get resistance. But we do see ivermectin sometimes being given out just kind of without much thought. But it's true, we don't, because once we lose ivermectin, I'm sure we can go to other antiparasitics, but the side effect profile of bad things can probably might go up with other therapies. And what do you usually? So you mentioned you do three treatments with your permethrin. So do you do one now, one in a week, and one another week, or one every 2 weeks?
I do 2. This study actually had the study was done with 3, but I do 2 rounds. The first round and then the second round, roughly 10 days later. And in theory, that's to kill any nymphs that have hatched that weren't affected during the first round when they were still unhatched. So typically I treat now and I treat again in about 10 days. I haven't seen a lot of permethrin resistance personally, but again, local epidemiology, I'm sure, comes into play.
And then do you kind of preemptively give them some topical steroids, knowing they're going to be still a little bit itchy after? What's your kind of post-scabetic regimen?
I do counsel on post-scabetic dermatitis and post-scabetic pruritus. I think it's important to see these patients back when they complain that they're itchy, because they really feel like you're taking care of them. And I saw someone back yesterday. She was complaining of post-scabetic dermatitis. She had a dermatitis. Her burrows were gone, but she had a dermatitis. And so basically, I got her tucked away, and she'll be better. The other thing I think that's really important is it's very important to treat the close contacts of patients who have scabies. And that would be like anyone who your patient shares a bed with, or anyone in the same household who has intimate contact. So I routinely will prescribe for everyone in the household. I don't have to see them personally. They may not be my patient, but I will still write them a prescription. The medications are very safe. I'm not worried about side effects. The main issue may be of cost, quite frankly. But I think it's important that we view scabies as kind of a disease of the community and not so much a disease of the individual. And if you're not treating the community, you're maybe not going to rid your patient of the disease. And if you need some sort of justification, there's the concept of expedited partner therapy that's utilized for STDs to prescribe doxycycline and such to partners. And so you can invoke that concept if you need something to back up your ability to write prescriptions for patients you haven't seen.
That's interesting. So will you just kind of really write it in the name of the family members, or do you just give? I sometimes will just give a high quantity to like the patient themselves.
I typically just write it for the patient's family members independently on a prescription pad.
Oh, that's great. And then what do you recommend for them? Usually it's for the home items, the couch, the clothes, bedding.
Right. Great question. I mean, again, in a low mite burden case of scabies, I think it makes sense to launder bedding and towels, but you don't have to go farther beyond that. The mites don't really live off of the human host very long, and there's not many mites. So you don't have to throw your shoes away. You don't have to throw your jacket away. But if there's items that you're worried about, you can always put them in a plastic bag and tie them up and leave them for a couple of days, and the mites desiccate. Of course, this all applies to temperate scabies, right? Which is kind of what we see here and what they see in Europe. But tropical scabies is a whole other discussion. It's almost it's a disease that has very different epidemiology.
So if we see someone come back from a trip and they're itchy and we diagnose scabies, we need to call you and ask you, how do we treat this very different subset? But it's interesting that the fear is very real and it's not even logical, right? Like I mentioned, even I came home and I was like, well, let's not risk it. Just throw everything away.
Yeah,
So I totally understand it for our patients too. It does it really does mess with their patient's psyche
you
most
bet.
times. I don't think I've seen anybody be like, okay, great, no problem. And then like not be really shaken to the core with an infection like this. So it's really interesting. I wonder where that stems from evolutionary. Like, why do we fear it so much? I mean, because we know even if you get it, it's very treatable. It's not life-threatening unless, like you mentioned, there are this few cases of getting this maybe a strep infection and that goes, so but like where does this irrational fear come from? And we've had actually other podcast episodes where we talked about just pruritus or itch in itself, not related to scabies, and how human beings like want to avoid someone who's scratching versus they don't want to avoid someone who's like in pain.
Mhm.
But like itch it just instills this primordial fear in us.
Mhm.
So I don't know if you kind of
Mhm.
reached into any of that. Like, what is going on in our brains? Why do we fear itch so much?
Yeah, that's a great question. It's got to be something evolutionary.
Yeah, because if you think about it, I can't think of too many. Well, I'm sure if we think about it long enough, maybe we'll think of something, but there's not that many things that infest your skin that are necessarily going to kill you, right? Like kind of like you could treat them, but maybe back in the day you couldn't. Maybe that was leading to these other things, or maybe it was the medical treatments that the patients were getting that ended up,
Back
being their demise.
back in the pre-antibiotic era, I think scabies was a lot more dangerous because it led to infectious complications, and in fact, there was a lot of morbidity and mortality from scabies during the trench warfare of World War One. Yeah, in today's day and age, it's pretty treatable, eradicable, but not always.
That's true. Yeah, it's probably just stemming from so much of that history. Even though we have treatments now, it's just like deep within our psyche. But this has been so great. Thank you so much for teaching us about this. So excited for your book too. If there's a link to it, we can also post it below the show notes. And of course, we always end our podcast with what you're excited about for the future of dermatology. Anything specific that comes to mind?
Yeah, thanks for. I think dermatology is now taking scabies seriously, and I think we're entering an era potentially of there being new diagnostic techniques coming down the pipeline. They're all being researched. Potentially PCR is one of them, and then new medications. We need them, and there are medications in the pipeline as well. There's a medication called moxidectin, which is FDA approved for onchocerciasis. Ivermectin was also FDA approved for onchocerciasis. I think it's pretty clear that moxidectin is going to be effective in treating scabies with a single dose, and that's right now in FDA clinical trials.
That's amazing. Yeah, we definitely need more treatments. And for some reason, people still hate scraping in clinic. Maybe it adds time. So other modalities for therapeutics and diagnostics would be fantastic. But thank you so much. Thank you for joining us.
Thank you.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.